the Miller-McIntyre Periodontal Prognostic Index. This can be found on my web textbook, pdmillerswebtextbook.com. The video you're watching now is on the development of the concept as well as the background. This is a part of a series of several videos, and the next video you will watch will be on the clinical application. And if you're interested in implementing it into your practice, there's a video on exactly how to do that. Smoking was found to be the most significant factor in long-term periodontal prognosis, so I've done a short video on that, which you may find interesting. And finally, if you're presenting the concept to a study club or something, here's a very short video to use as an introduction. The index is used to determine the long-term periodontal prognosis on molars, but can be applied to single-rooted teeth as well. An example of how to do that can be found on this video by Dr. Michael Sonic, which talks about how prognosis was determined on anterior teeth. What do you say when a patient asks, how long can I expect my teeth to last if I have this periodontal treatment? Finally, we have the answer. The MMPPI is evidence-based, statistically validated. It's very accurate. It was published in the Journal of Periodontology in 2014. And certainly you should take the time to read and study that article before even watching these tapes. And in 2015, it received the Clinical Research Award from the American Academy of Periodontology. And here's the letter stating that it received the award. And I would like to emphasize that the Academy reviews all the articles published the year before and selects only one article that they think should receive this award. So this has the stamp of approval, if you will, from the American Academy of Periodontology, and here I am receiving that award. How was this index derived? It was derived using data from my private practice based on a complete periodontal exam and history. Data was collected on 816 teeth, molars, on 102 patients. The inclusion criteria eliminated about 90% of the patients that came into my practice because the average patient was 42 years old, and with the age 42, most patients had already lost one molar. So therefore, all patients had to have a diagnosis of moderate to severe chronic periodontitis, and this is the factor that eliminated so many patients because patients had to have all 8 of their first and second molars present at the initial exam. And finally, all patients were a minimum of 15 years post-treatment. So the years post-treatment, the minimum, as I said, was 15 years. The average patient was in the study almost 25 years, and the range was from 15 to 40 years. The 7 factors that make up the index include age, diabetes, smoking, molar type, probing depth, furcation involvement, and mobility. Now, the study began with patients that I saw in 1969, and in 1969, the term clinical attachment loss was not currently used. So therefore, we use probing depth. And certainly if you were going to do a prospective study, you would use clinical attachment loss rather than probing depth. Now, let's talk about diabetes mellitus as a prognostic factor. Interestingly, of the 102 patients, only 2 reported a diagnosis of diabetes mellitus. I was surprised that this number was so low. Therefore, we had to come up with a way of determining a score for diabetes, and I went to this textbook to determine the levels that we would use for that. Now, my colleague Gopal has been working with me since the inception on this, and recently published an article on a prospective study where he evaluated diabetes and found that the scores that I'm going to show you in a moment are actually valid. So now we do have validated scores for diabetes mellitus. So what are the scores? First of all, if you do not have an A1C on a patient who has diabetes mellitus, then temporarily you can use a score, can be assigned to that. But certainly we would like to have an accurate score. And one of the problems that we have is if we suspect a patient is diabetic and we send them to the physician for determining this, it takes a long time for the patient to get back to you, and in all probability, the interest in having periodontal treatment has waned. So therefore, I would suggest that you look at this A1C now, which is an office-administered score, which you can get in packs of 20 from Amazon, and the cost if you do it in the office is about $12 to $16. And getting this information accurately to the patient on the day of the examination certainly has a positive effect, I think, on case acceptance. Now here is a typical A1C score, and as an adult with adult onset diabetes, most physicians suggest that the scores be kept at about 7. So here's a 7.1. The impact of smoking. Patients who smoke, when compared with patients that don't smoke, have a 246% greater chance of losing their teeth to periodontal disease. This is a statistically validated score by a recent study by Gopal as well. How significant was smoking? 4.9% of patients were heavy smokers, at least a pack a day. They lost 26% of the molars extracted. And ladies and gentlemen, that is a very significant factor. Now, a score of 4 for smoking was validated statistically and found to be valid by Gopal and his associates. Now, why a score on molar type? Well, originally molar type was not included as a factor, but when the extraction data was analyzed, 34.6 of all molars extracted were the maxillary second molars. For any of you that have practiced for any period of time, we know that the maxillary second molar probably is the most susceptible tooth in the entire mouth. Well, when the statistician saw this, she said, PD, I think you need to come up with a score for molar type. So we came up with a score, and we will show you that in a moment. Furcation involvement has little impact on long-term periodontal prognosis. Let me repeat that. Furcation involvement has little impact on long-term periodontal prognosis because data from multiple studies suggest a high level of tooth retention when compared with implant-supported restorations. And this is just one of the studies that I will cite for you. A new clinically accurate way of determining mobility. I think if you will look at this class of mobility, you will find it to be very clinically significant and provide you a better understanding of what mobility really means. Class 1 mobility. Although the tooth is mobile, clinically, you as a clinician are not concerned that the mobility is impacting prognosis. For instance, lower anterior teeth with short roots, typically we can move slightly, so you may want to score those a 1. Class 2 mobility. The clinician feels that the mobility is impacting prognosis, but let's look at 2 separate cases. You have a 29-year-old patient that you can move the second mandibular premolars and they are edentulous in the molars, and the patient is going to have a lower free end saddle partial. Well, I think anybody placing clasp on lower premolars in someone that age would be concerned about the mobility, so you would score that a 2. Fast forward to a patient that's 75 years old that has all their molars, and yet you can find exactly the same level of mobility that we found in the younger patient, but would you be concerned about the mobility? The answer is no. So in that case, rather than score it a 2, you would score it a 1. Typically, we think as a class 3 mobility that teeth are hopeless, but we need to rethink that because a lot of teeth are significantly mobile but are not necessarily hopeless. Let's take, for example, a patient that has had significant orthodontics and has had significant root resorption, and the teeth are quite mobile. You may want to classify that a class 3. But think again. Here we have teeth that maybe only have a gingivitis, and certainly you would not condemn them even though they're class 3. So let's think in terms of this class of mobility, this classification, for I think this becomes more clinically applicable. We now have all 7 factors statistically evaluated. Now let's look at the statistical evaluation. The statistical model that we used was the multivariable proportional hazard model, and we can see the 7 factors, and in the column hazard ratio you can see numbers. The lower the number, the least significant the factor. And you will see a 3.46 on smoking compared with a 1.27 on age, and look at frication, 1.21, where we statistically validated what I said earlier, that frication involvement is not a particularly significant factor in molar prognosis. So those factors that were lower are scored in a light blue. We can see that smoking was the most significant factor, and as you would expect, probing depth and mobility were significant factors, and they were almost equal. Why do we use a hazard ratio rather than a relative risk ratio? First of all, this was one of the few studies that evaluated molars during the initial exam, whereas many evaluated the molars only after treatment had been done. And we only took out 32 molars, or 3.9%. Then in maintenance, we lost another 143 molars, or 17.5%, but these teeth survived on an average of 15.4 years before they were extracted. So therefore, the total number of extractions was 175, or only 21%. Let's take a moment now to view the score sheet. And you will see on the top left where we have the age factors, and we can see various comments on there, and we will come back to that a little bit later. So results from the Cox proportional hazard ratio. Each line represents a score, and then if we draw a vertical axis at, say, age 15 years, we can determine the prognosis. In other words, if you have a total score of 1, you've got a 98% chance of keeping the teeth for 15 years. If you have a score of 4, you've got a 95% chance of keeping the teeth for 15 years. If you have a score of a 5, 93.6, and so on. So let's go back to what we were talking about a moment ago. 641 molars survived, or nearly 80%. And I know what's going through your mind. PD was keeping a lot of molars that really needed to be extracted. But then we look at this position paper from the American Academy of Periodontology, where they're talking about survival in health. And of the teeth that survived, these surviving in health were characterized by an absence of inflammation, which appears clinically as redness, suppuration, and bleeding on probing. So what we did at the exam, post-op exams, if there was no redness, if there was no suppuration, and the teeth did not bleed on probing, this was considered health. Now, of the 641 molars that survived, 561, or nearly 90%, met the AAP criteria for survival in health. So we were maintaining basically healthy teeth. But what if teeth are going to be maintained for many years, in this case 24.2 years? Some retreatment is going to be necessary. We now have the answer. The frequency. Some retreatment will be required every 6.7 years. The treatment will basically be non-surgical, but in 40% there would be additional surgery, according to this study by Fardall and her associates. For those that are using the laser surgery, perhaps some laser treatment would be required every 6.7 years. So the statistically validated scores for the 7 factors are as we see here: age, smoking, diabetes, molar type, probing depth, furcation involvement, and mobility. But the keys to success, if you're going to have this level of success, is you have got to have complete patient cooperation. They have to brush and clean interdental daily. They got to clean the posterior third of the tongue, where 90% of the bacteria are left after brushing and flossing. And these are the bacteria that cause halitosis or bad breath. And there is a video or two on the web textbook that address cleaning the tongue. They have to adhere to the recommended maintenance schedule. They got to complete the treatment that has been recommended. And if they're diabetic, they need to control their blood sugar. And if they're smokers, they need to stop smoking. And here we have, for smoking counseling, we can call 1-800-QUIT-NOW, where patients can get counseling 24/7, 365 days a year. And you can also view the video I mentioned earlier on the way that I taught smoking cessation. So here's the score sheet we talked about. And one of the things I want to focus on is the top right. We want to keep the goal below a 5. For we found that if the score was 4.63 or less, patients seldom, if ever, lost a tooth. So let's keep that score below a 5, which means we use a little ditty that's sort of corny, but it does make a difference. If you want to keep your teeth alive, keep your MMPPI below a 5. Here's a significant finding. In the first column you see on the left, circled in red, we want to score the patient at the examination. And then at the examination where it says treatment, we need to give them a target score to strive for, because patients need a goal. And this is a recent addition, and I think it is very impactful. Then we see 2 areas where you can do post-treatment evaluations. For instance, the first patient they see, the first time they see the hygienist later, she can score them at that point, and the patient has the initial score, the target score, and then they can see how close they came to the target score. So here are our conclusions. Young patients with moderate to severe disease can have an excellent prognosis if their disease is treated aggressively. By aggressively, I mean in depth. But if you've got a 25-year-old patient that's got 7 and 8 millimeter pockets, the perception is that they have a poor prognosis and are not offered surgical treatment, but are only offered non-surgical treatment, and the likelihood of getting the debris off the roots is unlikely, and in all probability we will have a self-fulfilling prophecy that that patient has a poor prognosis. Give these young patients a chance. Give them the opportunity to treat their disease in depth. And as we've said many times, smoking is the most significant factor in determining a periodontal prognosis. And third, as we've said over and over and over again, furcation involvement is not a significant factor in determining prognosis and should not be used as a criteria for extracting teeth. The next video in this series is on the clinical application of the technique, which I think you will find interesting. It also is very motivational in having patients accept, complete treatment, and follow up with maintenance recall. So enjoy.